When we talk about research, not all studies are equally reliable. Some studies provide stronger and more trustworthy evidence, while others are less reliable. Levels of evidence help us rank research based on how much confidence we can place in its findings. This ranking is especially important in healthcare, medicine, and science, where decisions about treatment, diagnosis, or policy depend on strong and accurate evidence. The criteria for ranking evidence include the study's design, how carefully it was conducted, its validity, and whether its results can be applied to real-world situations. For example, a systematic review of multiple randomized controlled trials, RCTs, on a new drug for diabetes is considered very reliable because it combines evidence from several high-quality studies. In contrast, an article where a single doctor shares their personal experience treating a few patients provides much weaker evidence. Understanding the hierarchy, evidence can generally be divided into high-quality, filtered, evidence and lower-quality, unfiltered, evidence. High-quality evidence comes from studies that have been carefully designed, critically reviewed, and synthesized by experts. This includes systematic reviews, meta-analyses, and critically appraised articles. These studies reduce bias and increase confidence in the results. Lower-quality evidence comes from studies that are less controlled, like case series, case reports, or expert opinions. While this evidence is still useful, it carries more risk of bias or error. Levels of evidence explanations. Level 1 evidence. Level 1 evidence is the highest quality evidence. It usually comes from high-quality randomized controlled trials, RCTs, or systematic reviews of multiple RCTs. Randomized controlled trials, RCTs, are studies where participants are randomly assigned to different groups. One group receives an intervention, such as a new medication, while another group may receive a placebo or standard treatment. Random assignment reduces bias and makes the results more reliable. RCTs typically have large sample sizes, often hundreds or thousands of participants, and follow strict protocols. Systematic reviews are studies that collect, evaluate, and summarize all relevant RCTs on a particular topic. The authors critically assess the quality of each study and combine the findings to provide a clear picture of the evidence. Level 1 evidence is used to guide clinical decisions, create treatment guidelines, and develop policies because it is very trustworthy. Level 2 evidence. Level 2 evidence includes lesser quality RCTs or prospective comparative studies. These studies are still strong but may have smaller sample sizes, minor methodological flaws, or inconsistent results. Prospective comparative studies are studies where researchers follow two or more groups over time to compare outcomes. For example, one group may receive a treatment and another does not, and researchers track their progress over months or years. Prospective studies are planned in advance and collect data as events happen, which makes them more reliable than studies that look back at past events. Level 2 evidence is often used when Level 1 evidence is not available or to support findings from high-quality trials. Level 3 evidence. Level 3 evidence comes from case control studies or retrospective comparative studies. Case control studies are studies where researchers start with participants who already have a condition, cases, and compare them to participants who do not, controls. They then look backward to see if there were exposures or risk factors that caused the condition. These studies are useful for finding associations but are more prone to bias because they rely on past data, which may be incomplete or inaccurate. Retrospective comparative studies are similar because they also analyze data collected in the past rather than following participants in real time. Level 3 evidence is helpful for understanding risk factors or causes of diseases, but it is less reliable than prospective or randomized studies. Level 4 evidence. Level 4 evidence includes case series or diagnostic studies with poor reference standards. Case series are studies that report on a group of patients with a similar condition, describing their outcomes or experiences. There is no control group, so it is harder to know if results are caused by a treatment or other factors. Diagnostic studies with poor reference standards are studies that attempt to evaluate a test or diagnostic method but do not use the best methods to confirm results, which reduces reliability. Level 4 evidence provides useful information, especially when higher-level studies are not available. But conclusions should be drawn carefully. Level 5 evidence. Level 5 evidence is expert opinion without formal critical appraisal. Expert opinion comes from specialists based on their knowledge and experience rather than systematically collected evidence. This might include reviews in textbooks, guideline statements, or advice from professional committees. While experts can offer valuable insights, their opinions may be influenced by personal bias and are not as reliable as data from controlled studies. Level 5 evidence is often used when no other research is available, or as background information for forming hypotheses or initial clinical guidance. Levels of evidence are not standardized universally. Different organizations, journals, and textbooks may create their own hierarchies based on the type of studies, methodology, or purpose. Evidence can also be filtered or unfiltered. Filtered evidence means that experts have already looked at the studies carefully. They check if the research is well done, compare results from different studies, and summarize the most reliable findings. Because experts have done this work, filtered evidence is more trustworthy. Example of filtered evidence: a systematic review of several clinical trials on a medicine. The authors read all the studies, combined the results, and decided which findings are strong and reliable. Unfiltered evidence is raw research that comes directly from individual studies. It hasn't been reviewed or summarized by experts. This evidence can still be useful, but it may have mistakes, bias, or weaknesses. Example of unfiltered evidence: a single case study of one patient who tried a new therapy. It shows what happened in that one case, but it doesn't tell you if the same result would happen for many people. Grades of recommendation. Alongside levels of evidence, research also uses grades of recommendation to guide how strongly a finding should influence practice. While levels of evidence tell us how reliable a study is, grades of recommendation indicate how confident we can be in applying the study results to real-world decisions, such as patient care, policy making, or clinical practice. Grade A, based on the highest quality evidence. Includes systematic reviews of well-designed randomized controlled trials, Level 1A, and individual RCTs with precise results, Level 1B. These are the most reliable studies for guiding decisions. Level 1A, this includes systematic reviews of multiple randomized controlled trials, RCTs, that are similar, homogeneous, in their methods and results. Systematic reviews summarize all high-quality RCTs on a topic and provide strong conclusions. Level 1B, this includes individual randomized controlled trials with narrow confidence intervals. These are studies where participants are randomly assigned to treatment or control groups, and the results are precise and consistent. Grade B recommendations are moderately strong. The evidence is good, but it may have some limitations, such as smaller sample sizes, less rigorous methodology, or less consistency across studies. Grade B can include Level 2A, systematic reviews of homogeneous cohort studies. Cohort studies follow groups of people, cohorts, over time to see how exposure to certain factors affects outcomes. These reviews combine the results of multiple cohort studies. Level 2B, individual cohort studies or low-quality randomized controlled trials. These studies are still useful but may have fewer participants, design limitations, or less precise results. Level 3A, systematic reviews of homogeneous case control studies. Case control studies compare participants with a condition, cases, to those without, controls, to identify possible causes or risk factors. Level 3B, individual case control studies. These provide useful evidence but are more prone to bias than systematic reviews. Grade C recommendations are weaker because the supporting evidence is limited or lower quality. Grade C can include Level 4, evidence comes from case series, low-quality cohort studies, or low-quality case control studies. Case series describe outcomes of a group of patients with a similar condition but do not have a comparison group. Low-quality cohort or case control studies may have small sample sizes. Inconsistent results, or methodological flaws. Grade D recommendations are the weakest and are based mostly on expert opinions rather than systematic research. Grade D can include Level 5, expert opinions based on non-systematic reviews of results or mechanistic studies. Mechanistic studies explore how something works in theory, but they may not directly test outcomes in real people. To recognize which level of evidence a research article belongs to, start by looking at the study design, sample size, and methods. For example, in this study, the design is clearly described. Patients were selected using simple random sampling, which indicates a controlled approach. Next, check if it's an experimental or observational study. This study has an intervention group and a control group with patients randomly assigned, which makes it a randomized controlled trial, RCT. RCTs are considered level 1 evidence if properly designed because randomization reduces bias and allows for strong conclusions about the intervention's effect. Also, consider the sample size. This study calculated the minimum required number of patients using statistical software and included enough participants, 90 patients randomly assigned, which strengthens the reliability of results. Look at the tools and measurements. They used validated scales like the MASCC Antiemesis tool, FLIE, and Dranitsaris scoring system, which adds credibility and ensures that outcomes are measured systematically. Finally, examine the study procedures. They clearly define inclusion/exclusion criteria, intervention methods, and follow-up, showing that the study is well-controlled and reproducible. Based on all this, because it is a randomized, controlled trial with clear methods, adequate sample size, and validated measurement tools, this study would be classified as Level 1B evidence, which is individual high-quality RCT evidence. You can recognize the level of evidence of any article by checking which criteria it meets across the different levels of evidence discussed above. By carefully examining the study design, type of comparison, sample size, method of data collection, and use of randomization or controls, you can match the article to the level that best fits its characteristics.